Hello everyone, my name is Jen Nolan and Musculoskeletal Australia is pleased to welcome you to our webinar this evening on the topic of diagnosis of and management approaches to musculoskeletal related headaches. In addition to tonight's webinar, Musculoskeletal Australia has two other webinars scheduled for the remainder of the year. You can purchase these webinars individually or as part of our series, with the recordings of previous webinars available for purchase at any time. Before introducing our presenter for this evening, I have a couple of housekeeping issues to run through. Firstly, if you have any technical issues during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Rebbeck Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of her presentation, you can type questions for her at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. I'd also be very grateful if all participants could take a moment during question time to respond to our feedback survey. Our presenter for this evening will be Dr. Trudy Rebbeck. Trudy is a specialist musculoskeletal physiotherapist with an area of clinical expertise in the management of headache, dizziness, whiplash and neck pain. She is the co-director of Sydney Specialist Physiotherapy Centre and Australian Specialist Physiotherapy Education. In addition, Trudy is a senior research fellow at the University of Sydney, a training facilitator and examiner for the Australian College of Physiotherapists. Her current research focuses on discovering new mechanisms behind musculoskeletal pain disorders and developing novel clinical pathways of care to translate these findings. She has been awarded over $5 million in competitive research grants and has over 40 peer-reviewed publications. She has been an invited speaker at many national and international conferences and workshops in the area of headache, dizziness and whiplash. Without further ado, I'll hand proceedings over to Trudy. Thanks very much, Trudy.
Thanks, Jen, and hopefully welcome everybody. So thank you, Musculoskeletal Australia, for the invitation this evening. What I hope that I bring to you today is both things, I guess, as a clinician specialising in headache and cervical spine disorders, as well as my research background in trying to find out why people get these things. So I'm hoping that I'm able to bring to you that combination of clinical expertise and research knowledge. So there'll be a couple of questions as we go through, or a couple of opportunities for me to get some feedback from you. So if you could type some things in the speech bubble on the left-hand side in relation to my questions, that would be great. So we might begin. I'm hoping that at the end of this evening you have a bit more of an understanding about how to triage musculoskeletal headaches and a little bit more of a knowledge of the process around how to differentiate headaches through history.
Okay, so sorry everybody, there seemed to be a technical hitch there. I'm going to start from where we left off. So we left off with headache being the second leading cause of years lost to disability worldwide, and then we went to 50% of people having headache, and most commonly that being tension type, followed by migraine and then cervicogenic. What you can see from the data there is that it's equally prevalent amongst children. Why there's a burden in the problems was also put out in that call, and part of that is that there's symptoms and overlap between the diagnostic categories. So headache, which is largely still classified or diagnosed by symptoms, means that there's not a gold standard diagnosis, arguably. So treatments are not necessarily based on the mechanism and have modest effects. There's certainly a call for better diagnosis and targeted management. An example of the overlap between symptoms is given there by Shorstad, and what you can see on the bottom right-hand table is that symptoms such as nausea or photophobia and phonophobia, giving up my little pointer here, that are commonly seen in migraine are equally seen or seen in 25 to 30%, if you like, of people with cervicogenic headache as well. So symptoms alone cannot necessarily distinguish nor diagnose the headache type. So what should we do in terms of diagnosis? So I always find it easier if we kind of consider a patient. This was a patient that came to me that I learn a lot from. So she had posterior neck pain, as you can see on that slide, and she had intermittent right-sided headache, but it was really severe. So you can see from the intensity there that it was 10 out of 10, and she had left-sided arm paresthesia. So what I want you to think about right now is the clinical reasoning process of what type of headache she could have. So those of you that do have access to typing, just start to think, what types of headaches would you be considering someone like she might have with those symptoms alone? So whilst you're typing, what you should be doing is thinking of all the possible causes that could exist for that headache type. And your job now from a process is to funnel that down to the most likely cause. So I'm going to watch and see if anyone has some headache types. So ideally, I'd like you to kind of think of the most likely headache as number 1 to number 2 and 3. So I'll see if anyone types anything as to what they might be thinking. One of the models to help you differentiate or a model we might apply is Waddell's model of musculoskeletal triage. So the International Classification of Headache Disorders, just put out by Cephalalgia this year, actually in 2018, divides those headaches into 14 headache types. And that can be really hard for a clinician to kind of diagnose headaches for 14 headache types and hundreds of sub-headache types. So for musculoskeletal clinicians, I often say that think about Waddell's muscular triage and apply it. One of the reasons you do this is that patients are often worried that they have a secondary headache, right, or something really bad. But physiotherapists would commonly over-classify or over-diagnose cervicogenic headache because they probably see more of that. Whereas doctors and neurologists, once they've excluded there being a secondary headache, would most commonly diagnose or assume that there's a primary headache present. So if you apply Waddell's musculoskeletal triage, what we're doing here really is saying, well, if our job as musculoskeletal clinicians is firstly to exclude a red flag or a secondary headache, we should also think of radiculopathy perhaps as being like a cranial neuropathy. And that once we've excluded these two, what's left a primary headache or possibly secondary musculoskeletal headache. So that's just a model to apply. And so in the headache framework, from my perspective, if we think we could have any headache present, our job first is to rule out a red flag or secondary headache due to something nasty, rule out there being a neuralgia, and otherwise we'd be left with a primary headache or a musculoskeletal headache. And I've kind of focused on temporomandibular disorder, cervicogenic headache and tension type headache as our most common musculoskeletal headaches we would see. So what do we do first to exclude red flags? And then from a question perspective to you would be, what would you now differentiate at a triage level to make sure or to determine whether someone had a red flag? And I might ask you that as a question and just reflect or answer that down, or answer that if you can. So if you're happy to type what you might ask currently, feel free to type that in. I'll just see where people are at with their questions here. All right. So essentially, there might be a few questions that you ask. When we look at the medical model, then there are different things that people ask to exclude for red flags. I'm just going to pop that in there. So medical, think about 5 Ps being pattern, phenotype, patient factors, pharmacology, and precipitant. And this comes out of the work of Roger Cady, again, published about 4 years ago. When we think about temporal pattern, one of the things you may need to ask to exclude red flags would be that there are changes that are not readily explained. So normally a patient might say to you, my headache, I get it twice a week. And then all of a sudden that temporal pattern has changed. I'm getting it daily or it's more severe. The phenotype's the type of headache. So what are the types of headache might have been a dull ache and now suddenly is a really, really sharp pain. So change in the style of headache. Pharmacology is knowing the effects of certain medications, and particularly ones that can cause headache or headache withdrawal, and precipitating factors and knowing diseases that might contribute to headache, such as hypertension, heart disease, and not that pregnancy is a disease. and also knowing other triggers. So just think about asking those types of questions in terms of excluding red flags. Some of the signs associated with red flag headache are outlined there, such as papilledema, drowsiness, confusion, and memory impairment. So what Hayner and Matheson said, and that relates to the case you've just seen, is this. So if we think here that our case here, and you may not be able to see this here, but I'm just going to put something here. So what I'm circling here is the first or worst headache of the patient's life. So if this is a headache they've never seen before, it's a worsening pattern. That might be a red flag to you. Okay, this is getting worse, something else is going on. And the second column here suggests the possible diagnoses. And the third column then, the types of imaging or investigations that you might order. So in this instance, this patient had told us a couple of things. So she told me that she had a 2-year history of headache, but it was really bad and worsening in the last 2 weeks. She'd tell us that she'd wake okay, but the headache would come on at half an hour, in particular once she moved her head. She talked about having associated symptoms, constant dizziness, nausea, a heavy head and being foggy and confused, a droopy eye and being blurred vision, but no sensitivity to sound or light. She had a past history that involved a vestibular history, and she also had a CSF leak. But when she had headaches, she said they were very different to what she got now. She was desperate to have physiotherapy because physio had helped her previously. In fact, her physio had referred her to me. And so she was convinced that there was a neck-related component to her headache. Yet she'd seen 2 neurologists that had told her this was vestibular, one saying that it might be related to a labyrinthitis and the other saying that she had a vestibular migraine. So let's kind of think about some of the headaches that you might have been thinking she would have. Does she have a migraine? ICHD, or International Classification for Headache Disorders, would say these are the criteria for migraine. And I've just put for you the actual page for which ICHD will relate to that specific diagnosis. So you would know, for example, that a migraine should have a unilateral location, be pulsating, be moderate to severe intensity. But a lot of people forget to ask this question, and that is, what happens when you exercise? What happens if you do your routine activity? And a migraine will be aggravated by routine physical activity, and or a migraine will avoid that. And remembering that, of course, these symptoms are most commonly present, photo and phonophobia and nausea and vomiting. Vestibular migraine, which she'd been diagnosed with, is classified by ACHD in the A classification. And that's largely because there's a bit of controversy around the criteria to diagnose vestibular migraine. But when you look at what's required here is that they need to have migraine type symptoms as well as vestibular symptoms of moderate to severe intensity. And when you think about this case, she didn't tell us she had spinning vertigo, or she didn't tell us she had typical vestibular symptoms. She also didn't tell us that she had photophobia or phonophobia. So some of the symptoms that are associated with vestibular migraine were in fact absent with her. Sorry, I keep pressing the wrong click button. What about, are we worried about there being something bad going on in her brain? And I think one of the things about, for example, headache attributed to a non-vascular intracranial disorder is what you can see is ICHD require that disorder to be diagnosed. Headache comes on when the intracranial disorder comes on, and it goes away when it goes away. So it doesn't really help us because they haven't yet diagnosed the disorder. So what do we think after the history from this patient now? We've taken that history and hopefully we're thinking, well, yes, there's enough of her associated symptoms, the intensity of that headache, the fact that it's worsening, the fact that there's associated symptoms that might make us think there's a red flag present. We know that she's been diagnosed with vestibular migraine by neurologists who know a lot more about headaches than most people. So essentially that's got to be in the mix of our differential diagnosis. But she's convinced that there's a neck-related component to a headache, and she's convinced that it's associated with her neck pain. So we have to have a musculoskeletal headache in amongst that differential diagnosis. So there are kind of ticks, if you like, in these categories. But it didn't really fulfil the criteria for cranial neuralgia. I'm going to stop that story for a minute and just introduce you to another patient, just to facilitate the learning for the rest of the webinar. So we have a complete different presentation here. So this is again a female, but she has more moderate neck pain, 3 to 8 out of 10, as you can see, and a headache that she gets 4 times a week and moderate intensity. And there's some associated arm pain. The difference for her is that her headache came on after a rear-end motor vehicle accident, that there was a trauma associated with it, and her routine workup meant that she'd had the usual things, and medications and physio, but she did say that physio had made her worse, her headache worse. And she'd seen some specialist medical people as well. Again, different to our other case here, she said that her headache was aggravated by neck pain. The neck pain made her headache worse. And both those were worse after sitting by looking backwards. And she could get, her headache was better when she exercised or went for a walk, which gives you a few hints. She could wake with a headache, but usually it would come on when her neck pain was worse and worse as the day progressed. So again, if you go through that same hypothesis generation, and some of you might be happy enough to flick down some answers here, what would you think may contribute to headache, or sorry, might be the hypothesis of her headache? And so I'm hoping that you have a 1, 2, 3 there as well. She might have headache type 1, 2, and 3. So just mentally note those or jot them down if you like on the feedback in the screen. All right. And then the other question is, what would you normally do to differentiate between the common musculoskeletal headaches, which are those that are listed there? What might help you differentiate between cervicogenic and tension type, and cervicogenic, for example, and headache due to temporomandibular disorder? So just have a think from yourself how you might do that. And then if we go to, I'm hoping what you arrived at for patient B would be this. So essentially from a history perspective, she may have features of migraine. She may have features of tension type headache. Remember the blue are the musculoskeletal headaches here. She has features of cervicogenic headache. And she might have features of headache due to trauma, which is again a secondary headache. Not necessarily a red flag, but slightly red, because we need to check with trauma that there's not any intracranial bleed. And again, because there's some unilaterality to a headache, we might consider a cranial neuropathy. So there's several headache types that you might be having up there as a result of her the diagnosis of her initial presentation. So let's think of what ICHD do to differentiate between those different headache types, or at least from a classification perspective. Reminding you, and you know that for episodic or frequent episodic tension type headache, some of the criteria, bilateral location, pressing, tightening. But the key thing I think we should be asking people is what happens when you exercise? And essentially here, they're not aggravated by routine physical activity. And they should have none of these, so no nausea or vomiting or photophonophobia. And that helps us kind of differentiate. So if it's not in your routine questioning, make sure you ask people about physical activity and what it does to their headache. What I put up here for cervicogenic headache that's new from ICHD3, from ICHD2, is that you can have clinical evidence of neck, if you like, the cervical spine or soft tissues of the neck causing headache, not just imaging evidence, which ICHD2 had. And essentially the causation of the headache is by at least 2 of the following: that the headaches come on at the same time as the neck pain, and that it gets better, obviously, so it gets better. But we should be able to produce the headache through cervical range of motion or provocative movements. Not necessarily do you have to have the headache abolished by diagnostic blockade. The other thing that we had up there for this patient was a cranial neuropathy, and I think the most important thing for us to make sure is that it's not an occipital neuralgia. And again, I've highlighted the red bits here about what occipital neuralgia might be around. What some of the criteria might be. So you have to have at least 3 of these characteristics. That there are paroxysmal attacks that last for seconds to minutes. They're severe intensity, shoot or stabbing or sharp in quality. In our patient B didn't necessarily have those. From a physical examination perspective, trigger points, particularly at the emergence of the greater occipital nerve, or at least dysesthesia or allodynia during a stimulation of the scalp. So some of the easy things you can do is just touch the scalp and see if there's allodynia, And I'll show you where to look for a trigger point for the great occipital nerve. If you think that if you did have trauma, one of the classifications from ICHD is headache due to whiplash. And what you can see is the criteria mean that just a headache and neck pain occur after the whiplash and should develop within 7 days. And for it to be persistent headache, it persists for 3 months. So in this instance, she would fulfill those criteria as far as a headache due to whiplash is concerned. Whilst this is not a lecture on pathophysiology of musculoskeletal headaches and migraine, it's just important sometimes to remember where current thinking is at in terms of the common neurophysiology between some of the primary headaches and musculoskeletal headaches. So I kind of put this up here to show, to represent, I guess, schematically that, as you know, the cervical afferents and dual trigeminal afferents converge in on the trigeminal cerviconucleus. And the second order neuron, if you like, they synapse with the second order neuron that goes up to the cortex and then the thalamus. Represented here, that's how information goes into the brain, and then the brain regulates that by either inhibiting that information or facilitating it. So where the physiology may be common here is how it converges. So just reminding you that from a cervicogenic perspective, you're thinking that the primary nociceptive structures involved in cervicogenic headache can be anything innervated by the upper cervical nerves. And so you should be thinking about joints, ligaments, dura, muscles that are all innervated and then come into the trigeminal cerviconucleus through the upper 3 cervical nerves. What's slightly different about tension type headache is the nociception has its source in muscles. Yet again, those same muscles then converge upon the trigeminal cerviconucleus through the same neurophysiological pathway. Migraine also, whilst its primary form of nociception is in the meninges of the blood vessels in the brain, still comes through the trigeminal ganglion before the second and third order neurons go up to the cortex, which I've just written on the right hand here, cortex, which I've just written on the right hand here. The thing that's probably important or maybe differential as far as the history is concerned with migraine is that migraine would have non-musculoskeletal triggers as well. And so I'd ask you to kind of think for a minute, what might be some of the non-musculoskeletal triggers that you know trigger migraine? And hopefully if you think about that for a minute, some of you are answering things such as food triggers, hormonal triggers, light triggers, stress triggers. So they're if you like, musculoskeletal triggers. So, all right. The thing about pathophysiology of migraine as far as, particularly this is probably more in migraine aura, is knowing that there's cortical spreading depression that occurs. My point of having this slide on here is that when we're getting, in migraine, when we're getting essentially central sensitization of the trigeminal cerviconucleus, that then maintains the headache. And in some people, that might be called chronic daily headache or chronic migraine that just persists and doesn't change. But what's understood now is that this is a complex genetic disorder, and some people that may in fact get persistence of headaches, other people don't, and that may be genetic in nature. So one of the questions you need to ask perhaps in terms of differentiating migraine may well be this, and that is that if you have a family history of migraine, it doubles your risk of having migraine, and particularly if that's over 2 generations, it's 4 times the risk. So a routine question probably should be, is there a familial or is there a family history of headache? A lot of physios ask me about Dean Watson's work, and that's just up there to remind you about his work, particularly in demonstrating that head pain could be caused by a palpation of the cervical spine. And he was able to reproduce the same migraine headache and the same tension type headache in some of his patients. So it's just perhaps a little bit more evidence clinically that there's this common neurophysiology. So when we think about that and our differential diagnosis for patient B, She's telling us she doesn't have photophobia. There's not really a strong bilateral component to a headache. She does say that there's neck pain and it's unilateral. And she does have a history of trauma, although there's no loss of consciousness, so we're not necessarily think she's got a brain injury. And as far as the cranial neuropathy is concerned, it's not really paroxysmal or sharp. So what happens with her is the tics go in the cervicogenic headache and the tics go in the secondary headaches due to trauma. So do investigations help us with our diagnosis? So we've talked a little bit about history and the classification, and I'm going to just briefly talk about investigations before going on to physical exam. Also don't help us a lot, some recent work we've done in magnetic resonance spectroscopy, for example, this is where you kind of do spruik your own work, did show that when we look at brain neurochemicals, we see different concentrations of GABA, this is GABA aminobutyric acid in the brain, in migraineurs compared to controls. And this is one of the known inhibitory neurotransmitters in the brain. And so this kind of gives us some insight that in the future, perhaps, brain imaging may be useful, particularly when we start to understand more about the pathophysiology. And this slide is up there just to illustrate that GABA as an inhibitory neurotransmitter and glutamate as an excitatory neurotransmitter are understood to be involved in whether migraine is particularly facilitated or inhibited. So I think whilst it's preliminarily, we may in the future have more information about neuroimaging, and you may want to ask questions about that later. Other work tells us that fMRI, for example, or functional magnetic imaging, does appear to be different in migraine compared to other pains compared to controls. And structural changes are shown in migraine as well compared to controls. But what you can see is the odd ratios are quite low. So it's not like you're going to go and order an MRI just to see if there's some structural brain changes in a migraineur. It's not really going to help you with treatment. So where did I want to end off with our patient A here? So let's think about her and investigation. So this was an MRI brain, and you can't read that. That's why I brought up the information there. If you take a minute to read that, there's a couple of things here. Nodular thickening may be consistent with hypotension, and there's a stable pineal cyst. There's enough, so there might be some things in there that worry you or don't worry you. But in my mind, the question was, should she be referred for further imaging? She had enough probably in that imaging to tell me that we might be worried. But more importantly, it was the worst headache of her life, and she hadn't had it before. And so some of the things that I was thinking about, particularly because it was bad for her, would be, should we go and refer her on for CT angiogram or MR angiogram? And so particularly after investigations, we may well think, well, yes, her MRI is enough that would say, yes, we may need to go on and have further investigation. Whereas our patient B, I'm not going to go and send her off an investigation because migraine's not really in my hypothesis. It doesn't really help. There's not really some investigations that I can send her off for tension-type headache. And she did have an MRI of her cervical spine that showed us there was nothing sinister, but it doesn't really help us diagnose headache. She did have an MRI of her brain, which excluded there being any intracranial bleed associated with that trauma. So where do we go on the physical examination now to help us differentiate between these headache types and our two patients that I'm presenting tonight? You may have a usual framework around how you go about assessing someone with headache. And so I've just listed that there for you. For example, thinking about cranial nerve tests and thinking about assessing muscle, joint and neurological systems. So if you had tests that you might do for patient A or B, I'd ask you to reflect for a minute what you might do to help differentiate between patient A and patient B's headache types. So that's just giving you a second to think about it. And then we'll go on to what happened. So for patient A, we were thinking she might have a red flag, and so one of the more important things to do might be a cranial nerve examination, and I've put that up there for you. What I find most useful is the oculomotor component of that. And indeed, in this patient, when we did an ocular motor test, it made her dizzy. It did. She had saccadic movements, and so it made us think that maybe there was something else going on that hadn't yet been sorted out. Secondly, with her, when she did one repetition of cervical flexion, so she just bent her head like that, that gave her the 10 out of 10 headache straight away. So that was just me going, you know, I'm stopping here. And so I think it's really important, that process. I've just produced you 10 out of 10 headache with one movement of your head. That is not a musculoskeletal headache. And so we need to be strong enough to go, no, off you go, you're not, this is not something that we can help. But yet she begged me in that consultation to continue to treat her. So essentially, this is the process we want to come up with, triage, diagnosis. And I'll go through that later, I think. So what does she end up having? She ended up having a pineal cyst that was considered to be symptomatic. And one of the reasons for that is the size of it was believed that when she did cervical flexion, it then obliterated the CSF to the point that it increased her headache. That was what the thinking was. And the thinking was by her neurosurgeon, who she went to see, who then resected the pineal cyst. And you can see in the article that he then published was that some of the things for when pineal cysts may be symptomatic are when headaches are associated with symptoms such as nausea, vomiting, drowsiness, visual disturbance. And you can see she had many of those things. So this patient ended up having a resection of that pineal cyst, and she was completely symptom-free. So the learning from that were twofold from her perspective. One, please listen to your patients. She was adamant that it wasn't a vestibular migraine. And two, when things don't fit, please, seek further help. And in essence, she found some answers with that further help. Let me finish off, I guess, and I'm rushing through this a bit because of the delay, to make sure we get through the important slides now from a physical examination perspective. So I'll just skip over a couple of things. If we think from a cervicogenic headache, we want to really look, do we have an articular, a muscle or a nerve component to that? That might help us target our management a little bit more. So remembering that we have to exclude a cranial neuralgia, and I said to you that I would talk to you about how to do that. So some of you might be able to feel that greater occipital nerve if you go to the midline of your scalp and just come to the side a little bit. And if you run your fingers across that, it's quite tender. But for most of you, it'll just be tender. It won't actually refer the headache. Remember we said in occipital neuralgia, as you run your finger over that, it will spike that headache and run it up over your head. Or if you just innocuously touch the scalp like this, it might be allogenic and create the headache. And that's what we'd expect in occipital neuralgia. However, if we want to look at the articular system, our manual examinations discriminate cervicogenic headache really well with 80% sensitivity. So some of the new data here, such as the flexion rotation test, are equally helpful for you to discriminate headache. So for example, the flexion rotation test has an average of 44 degrees. So you can take someone right up into flexion and rotate. And what you can see is it can reduce significantly in cervicogenic headache compared to migraine and other groups. So it can be a quite useful test for differentiating. Equally, muscle tests can be helpful to differentiate between cervicogenic and tension type headache. And part of that is that when you look at the strength tests here, you can see that a cervicogenic headache is much weaker in pure isometric strength of extensors and flexors in the cervical spine compared to both migraine and tension type headache. And they have poorer performance on the craniocervical flexion test. So that can be useful to differentiate. Most of you be familiar with the craniocervical flexion test. And if you're not, you might have to learn how to do that. But I've got to go to my other video if I can. Just show you what an abnormal one looks like. I'm just going to play that for you. And what you can see there is you've got increased activity of the left side sternocleidomastoid here that's quite noticeable in this patient, and that's typical of what you might see in a cervicogenic headache.
So come back a bit and do it again.
Stop that video and go to the next one. Equally, the cervical extensor test, which is looking at performance of the cervical extensors. I'm playing that video for you there. But in someone, the cervicogenic headache will dominate that action with the craniocervical component, and they'll have less activation or less movement in the lower cervical spine. So those are some of the things that you might see. I'm just going to close that off. I need to go back to my slides. Good. Okay. Tension type headache, what the ICHD here say is if you palpate the muscles known to cause tension headache, so frontal, temporal, masseter, pterygoid, sternocleidomastoid, and get a tenderness score from 0 to 3 and sum that score, higher scores are associated with tension type headache than lower scores. So that can be really useful as a test to test for tension type headache. So what about our patient B? I'm going to try and finish this and rush through it. I know we're running late because of the technical hitch. Our patient B had reduced cervical range of motion and could not extend her head beyond the midline, which is what that looks like there. I know this is a male, but she had poor muscle performance primarily, and I've listed some of those things there that you can go and look at later, but particularly in flexors, extensors and axioscapular control. And she had pain produced by palpation of the cervical spine, which we need for cervicogenic headache, particularly at C1. But what you can see is no tenderness on palpation of her greater occipital nerve. So when we look at our differential diagnosis for our second patient, then we can see that, again, because she had positive findings for cervicogenic headache here, reduced range of motion, pain on palpation, poor muscle performance, she fulfills those criteria, but equally they could be there in headache due to whiplash. So how does that help us in management for my final few minutes so we allow for some questions? I'm just going to briefly show you the medical management for cluster headache based on clinical guidelines, mostly triptans. Highest evidence for migraine is around, for prevention is beta blockers, and for episodic migraine treatment is triptans. But I just returned from IASP last week, and importantly with your calcitonin gene-related peptide is now showing as one of the mechanisms for headache, and one of the more recent randomised controlled trials is showing that some of the antibodies for that when treated are giving very good effects. So I'm just putting that there so that essentially migraine treatment's in a change mode at the minute to look for anti-CRGP antibody management. Tension type headache, best evidence for soft tissue therapy and manual therapy, and cervicogenic headache, best evidence for a combination of manual therapy and exercise, less evidence for radiofrequency ablation. So when we talk about choosing treatments for our cervicogenic headache patients, how can we improve some of the effects that we're seeing in the randomised controlled trials and systematic reviews? Might be to direct treatment to the impairment. So what do we do for our patient here? Remember, she had lots of muscle impairments and she'd been aggravated by previous manual therapy. So the treatment really was around choosing a different manual therapy for a couple of treatments, which was a PIVM rather than PAVM, and then rehabilitating the flexor control, going through to endurance and extensor control during endurance. And I wrote that particular patient up in this article here for those of you that want to go and read that in more detail. The outcome slide's there for a purpose, and you can see that her headache frequency reduced significantly from 4 to 1 time a week, as did the intensity. Her impairments returned to normal and her net disability and function improved. And one of the important things I think we have to say for our chronic headache patients is not that we can cure headache, but we can probably significantly change the frequency and intensity of it by providing the right treatment. And most people are happy with that. It doesn't bother them so much, it's quite mild, compared to bothering them a lot more and being severe. So I'll flick through the TMD because we're running out of time, but you'll get that in terms of the PDF, but I do have that there for completeness in terms of how to screen for temporomandibular disorder. Essentially, the one slide that I might spend a minute on is this, that if you're getting headache to TMD, you've got to have headache in the temple and be modified with jaw movement and provoke the headache with either palpation of temporalis or provoke the headache with jaw opening or jaw movement, and it's quite sensitive and specific for picking up headache due to temporomandibular disorder. And ICHD3 say the same thing, that you've got to have at least 2 of those things: headache provoked on physical examination of temporalis palpation or passive movement of the jaw. Gonzalez had a screening questionnaire for it too. So what I wanted to end on maybe as a take-home message here, that the history is highlighted because either musculoskeletal headache or migraine, you're going to be able to differentiate that best with the history with some of the things we talked about, and investigations will play less of a role. And once you've come down to your hypotheses, the physical examination can help you differentiate between those different musculoskeletal headache types, and that then allows you to come up with contributing head impairments and targeted management. So I'm hoping that what we've covered here is a triage process effectively that you cannot really come up with a musculoskeletal diagnosis until you've excluded a red flag. And I gave that patient to you as an example about when it doesn't fit the pattern, don't hesitate in referring them to people that might well be able to sort them out. And she taught me a lot, I guess. Imaging has a limited role, but I think we'll know more over time. The key musculoskeletal headaches differentiating between would be cervicogenic, tension type, and temporomandibular. And in my view, if we're going to do better as musculoskeletal clinicians, we should be trying to find out dominant mechanisms here, more joint, more muscle, more nerve oriented, so that our management is more targeted rather than just being, I guess, random. Don't hesitate to refer if people aren't getting better, even within your own discipline, if what you're providing doesn't work. And remember, we're expecting outcomes with that to be reduction in headache frequency intensity by at least 50%. Some of you might not know how to do some of the tests, so plugging my own courses here, certainly on our website or with the APA, we do run courses on how to do some of those assessment techniques that I showed. But I'm going to end up there just to allow some minutes for questions. I'm going to stop now and allow for the Q&A. Now, you might be muted there, Jen. I can't hear you, but hopefully the questions will come through. So for Rebbeck, I can't hear Jen.
Okay, apparently I'm back on air now.
I can hear you now, yep.
Yeah, good. So, look, thank you, Trudy, for a magnificent effort in a reduced time. We've only got a few minutes for questions.
Okay, apparently I'm back on air now.
Could you please type in the chat box now?
Yeah, good. So, look, thank you, Trudy, for a magnificent effort in a reduced time. We've only got a few minutes for questions. If you have any questions, could you please type them in the chat box now? If we happen to run out of time, we might be able to...
might contribute to headache. Could you help us with that question, Trudy?
Yeah, so some of the, particularly medication overuse. So quite commonly, even sumatriptan, so triptans can often, if taken too much, produce a medication overuse headache. So that's one example. So the point for people listening is to ask how commonly or how often people are taking these medications. Preventative medications can do the same thing, not quite so often. So, you know, if you find people are taking triptans every day, the chances are they're going to have a medication overuse or a withdrawal headache from that. That's one example.
And another question, how are antibodies connected to migraine?
Yeah, it's tricky. I'll give you a couple of articles to read, but it's more that the gene-related peptide is essentially there's a receptor on the trigeminal cerviconucleus second order neuron that then seems to be or opens up in migraine, and there's an antibody that has been developed by researchers in Harvard Medical School that can close off that channel. And essentially, that's what I was trying to get at with that new research. So it's an antibody-based medication that stops that receptor.
Okay. Are there any further questions? If there are, could I ask people to type them into the chat box now? Because we're about to finish, and just to remind everyone that you will receive a recording of tonight's webinar, and Trudy has also kindly agreed to provide a copy of her presentation as part of the follow-up resources. So any further questions coming in? If not, we might finish there this evening. I'd like to thank everyone for joining us and ask that you respond to the feedback questionnaire which is on your screens now. Trudy, I'd like to thank you once again for a real trooper of a performance in dealing with that technical glitch and continuing to present as you did in a fine fashion. So thanks very much for the work and effort you put into this evening's presentation. And on that note, I bid everyone a good evening and thank you for joining the webinar this evening. Good night.
Thank you, everybody. Thanks for your time. Thanks, Jen.
The conference is now in private host conference mode.